I would like to welcome all who have joined us to participate in this important webinar, Medication-Assisted Treatment, or MAT, a focus on alcohol and opioid use disorder. I'm Dr. Perard, Medical Officer with CSAT SAMHSA. And as we all know, the use of medication to treat alcohol and opiate dependence as part of a comprehensive treatment approach has been extensively studied and shown to be the most effective practice in reducing substance use and increasing rates of recovery, yet the rate of adoption of those medications is pretty low. Screening and brief intervention is a first step in the prevention and treatment of alcohol and substance use disorders. Clinicians, however, are often at a loss when confronted with patients in need of further treatment. The purpose of today's presentation is to provide clinicians and administrators with a better understanding of the medication available to treat alcohol and opiate use disorders in order to facilitate adoption of medication-assisted treatment in office-based practices or outpatient clinical programs for treatment of alcohol and opiate use disorder. To help us address these challenges, I'm pleased to welcome a speaker for this afternoon webinar, Dr. Eleanor McCann-Skatz. Dr. McCann-Skatz is Professor of Psychiatry at the University of California, San Francisco. She is board certified in general psychiatry with added qualification in addiction psychiatry and is a distinguished fellow of the American Academy of Addiction Psychiatry. Dr. McCann-Skatz has been working in the field of addiction medicine for 20 years as a clinician, teacher, and clinical researcher. Her specialty areas include pharmacotherapy for substance use disorder, clinical pharmacology of drugs of abuse, drug interaction, cocaine, alcohol, and opiate medication development, and co-occurring HIV disease and addiction. She is the state medical director for the California Department of Alcohol and Drug Programs. She is also medical director of the Physician Clinical Support System for Buprenorphine, or PCSSB, and Prescriber Clinical Support System for Opioid Therapy, PCSSO, Center for Substance Abuse Treatment, SAMHSA-sponsored national training and peer support programs for physicians and clinicians treating patients with clinical needs for opioid medication. Dr. McCann-Skatz is developing educational curriculum to assist with the integration of substance use screening, brief intervention, and treatment referral through an SBIRT grant to UCSF. Internationally, she has been part of the WHO committee to develop guidelines on the treatment of drug users living with HIV/AIDS and has reviewed and contributed to WHO white papers on methadone and buprenorphine treatment of opioid addiction. Most recently, Dr. McCann-Skatz has been conducting studies of drug-drug interaction between opiates or alcohol and HIV therapeutic through research studies funded by NIAAA-NIH and drug interaction between disulfiram and HIV therapeutics funded by NIDA-NIH. Again, on behalf of SAMHSA, I would like to welcome you all, and I thank Dr. McCann-Skatz for being with us today. Dr. McCann-Skatz?
Well,
and I think we just
I'm sorry, do you want to say something, Leslie?
Yeah, I just want to let folks know, if you wouldn't mind muting your phone in the meantime, and if you have any questions, we're going to reserve those until the end. You can send me your questions, though, via the chat function at the bottom right-hand corner of your screen, and we'll be sure to get those asked at the end of the presentation.
Okay.
I think we're all set, Dr. McCann-Skatz.
Okay. Well, thanks for inviting me to give this talk today. I'm going to talk about the use of pharmacotherapies to treat alcohol and opiate use disorders. And let's see. And I need to tell you, first of all, that my only disclosures are my grant funding from the National Institutes of Health and the Substance Abuse and Mental Health Services Administration. What we're going to do today is review some of the basics of substance abuse treatment that can be accomplished in multiple medical settings. These pharmacotherapies can be given through primary care clinics, other medical settings, specialty care programs, mental health settings, and alcohol and other drug use specialty treatment programs. So I'm going to talk about the pharmacotherapy of alcohol use disorders and also talk about office-based treatment of opioid dependence. And I'm going to speak about FDA-approved medications for those two substance use disorders. I know that a lot of people on this call have SBIRT grants to train general medical residents and to also explore different effectiveness of different types of interventions that involve SBIRT in various populations. But I thought what I would do, just as an introduction to how we're looking at this at our program at UCSF, is to talk a little bit about how we're doing this so that I can sort of talk about how we put into practice the information that I'll give you about the use of medication, alcohol use and opioid addiction. So we use a single question screener as one of our components of SBIRT, and we use the question that was developed by Dawson and colleagues in the past year. Have you had any times when you had 5, if for men or for women, 4 or more drinks at one sitting? That question has been shown to have high sensitivity and specificity for both hazardous alcohol use as well as the detection of alcohol use disorders. If an affirmative answer is given to that question, then we encourage our clinicians to explore the alcohol use in greater depth, and then to offer advice for cutting back or stopping. If there's evidence of substance dependence, then depending on what the presentation of the individual is, they may need specialized substance abuse treatment, but also ongoing treatment can be accomplished in the various medical settings that I just discussed a moment ago. And let me just show you how we do this in our program. I'm sure everybody has a different way of doing this. But what we do in our general medicine clinics at UCSF is once a year, and we've been doing this for a couple of years now, once a year when people come in for a visit with their physician, they are given in the waiting area a form to fill out. And we've had no resistance at all from patients in filling out this form that you see on your screen now. We ask them their age, we ask them their gender, we ask them whether they consume alcohol at all, we ask them how many drinks per day and how many drinks per week they take in general, and then we do ask them, 3B is the question that's been validated by Dawson and colleagues, that looks at binge drinking of alcohol. We also go on and ask 2 other questions which don't have as much research validation, but we have found them useful. And one of them is, in the past year, have you used a prescription drug for non-medical reasons? And then the last question is, in the past year, have you used an illegal or recreational drug? And once the individual patient completes that, that is given to their doctor when they go in for the appointment, for the visit. The physician has instructions to help them to follow up whatever they find on that form, whatever the patient has told them on that form. And so we instruct our doctors to follow up on questions about alcohol use, and we ask them to quantitate in terms of how much alcohol is used. We ask them to follow up on yes responses to drug use, including prescription medications used for non-medical reasons, as well as illicit drugs, street drugs. And we then ask them, if they had an opportunity to talk with the individual about their alcohol and drug use, we ask them to classify use as DSM-IV substance abuse or dependence. We then instruct them to advise the patient about the safety issues if they believe that there are safety issues, and to recommend cutting down or quitting, and to offer to help the individual to do that. And then we ask them to take to use a question to determine the level of motivation. Are you willing to consider making changes with your substance use? And to record the individual's answer. We then ask them, what did they do? Based on all the information they collected, based on their determination of whether the person has a substance use disorder or hazardous use, and based on the level of motivation of the individual, we ask them, what did they do? Did they do a brief intervention, which we train our residents and physicians on doing? We ask them about establishing treatment contracts, and we ask them whether they completed a prescription monitoring program report. In California, that's called CURES. We do encourage our clinicians to complete CURES reports on individuals that are going to be prescribed controlled substances. We then give specific information to the clinicians about our intake program that we have in San Francisco. That's our treatment assistance program, including a phone number. And then we ask them to tell us what they ended up doing. Did they refer to a specialty treatment program, or did they arrange for follow-up with them or another of our physicians in our medicine clinic? Did they simply provide educational materials and self-help information, which we make available to all of our clinicians so that they can give that to their patients should that be the intervention they believe is needed, and whether they provided any medications. So we're tracking this in our clinics at this time as part of our SBIRT grant. So that is a means by which you can take information about how to screen, how to provide brief intervention, but take it further and teach clinicians on how to use pharmacotherapies in their practices for the treatment of substance use disorders. And so we do spend a fair amount of time offering training to our residents and to our faculty as well on the use of medication treatments to treat alcohol and opioid use disorders, and I'll go over some of that information over the next few minutes. First, in considering the treatment of substance use disorders, either alcohol use disorders or opiate use disorders, we have to think about what medications are available. One thing we know is that for alcohol, basically, there are two different types of treatment. One for physiologically dependent individuals. They would need medical withdrawal from alcohol. That's usually done on an inpatient basis because there can be complications of alcohol withdrawal that in some cases can be life-threatening. And so that is generally done on at an inpatient level of care. There are relapse prevention medications, which I'll talk about in a few minutes. For opiates, in addition to alcohol, opiates also produce physical dependence. And for the procedure of withdrawing someone from opiates, it's often done on an inpatient basis, but it can be done from ambulatory settings as well. Unlike alcohol, with the medical withdrawal from opiates, unless there is some other pre-existing unstable medical condition, withdrawal from opiates is generally not life-threatening, and so it can be done outpatient. But again, it's often done inpatient because a lot of times people that are opioid dependent will have other co-occurring conditions that put them at higher risk as outpatients. So they may have co-occurring mental disorders or co-occurring medical conditions that place them at higher risk, and so we do try to provide medical withdrawal on an inpatient or in a residential setting for those folks. And there are relapse prevention medications for opiates, which I'll talk about in a few minutes. But the relapse prevention piece of this is something that should be available to those with substance use disorders over a period of time. It's not something that occurs on an inpatient basis and then stops. These are medications that are meant to be used over time and to assist the person with developing new coping mechanisms so that they can maintain their abstinence over time. So it's important for primary care providers, psychiatrists, specialists to all be trained on this so that if they have an individual who needs this kind of a treatment, then they would be able to provide that over a period of at least months. So when do we consider pharmacotherapy for those with substance use disorders? We generally think about a number of different areas of impairment in a person's life and the severity of their medical, psychiatric, and psychosocial problems. You can use something like the Addiction Severity Index, which will give you an idea of the severity of these different realms in a standardized fashion. You can get this information from taking a history from the patient, but the decision about pharmacotherapy should involve an assessment of all of the areas of an individual's life that would be affected by their substance abuse. And that includes family issues, employment issues. Oftentimes these folks have pretty severe financial problems. The medical conditions that co-occur with the substance use disorder, legal issues, and psychiatric comorbidity, including there should be an assessment of the risk for harm to self or others. Those who have active addiction often can be quite depressed and anxious, and they do have risk at times for harm to self, particularly, and sometimes to others. It needs to be evaluated. And it's also important to take a look at the potential for relapse. Many patients will have gone through a number of abstinence-based programs. If those have not resulted in any significant sobriety, then those individuals should be considered for medication-assisted treatment. There's really not a lot of reason to believe that if somebody has been through several abstinence-based programs and has had little to no sobriety thereafter, that the next abstinence-based program is going to have a different outcome. I think those people deserve a chance with medication-assisted treatment. The higher the acuity or severity of their substance use disorder, of the issues that are part of their substance use disorder, the greater the need for medication treatment if there is such a treatment available. So I'm going to talk for a few minutes about medications that are used to help to prevent relapse to alcohol use and which are FDA approved. There are 3 right now. They are disulfiram, which is also known as Antabuse. There is naltrexone, both an oral tablet and an injectable formulation has been available for a few years for the treatment of alcoholism, and a camprosate. I want to let you know about some guidance on the use of these medication-assisted treatments. These are all available from SAMHSA, and they're really quite good. I think they're quite valuable. And so I'm going to have this slide for you and also a similar slide when we get to opiates. And also these slides will be available to you if you'd like to have them. But there are a couple of SAMHSA documents that I think are quite helpful in working with those who have alcohol use disorders. There's Tip 49, incorporating alcohol pharmacotherapies into medical practice, and there's a link there. You can go to that link and order this document if you'd like to have it. And then there's also a SAMHSA advisory on naltrexone for extended release injectable suspension for treatment of alcohol dependence. Now this This document is a few years old, but it's I think still quite relevant. It's short, it's easy to read, it gives a lot of really good information about the use of extended release naltrexone. And so I think that those of you who are thinking about these kinds of interventions might want to have a look at those documents. So let's talk for a couple of minutes about disulfiram. This is a medication that's been FDA approved for a long time now for the treatment of alcohol dependence, and it works in the following way. It blocks alcohol metabolism by inhibiting the function of aldehyde dehydrogenases. Aldehyde dehydrogenases are involved in the conversion of acetaldehyde, which is an intermediary in alcohol metabolism, to water, which is how your body eliminates alcohol. And when acetaldehyde metabolism is stopped by use of disulfiram, you get increases in blood acetaldehyde levels. And those increases in acetaldehyde will cause a noxious reaction, which is called, sometimes you'll see it called the DER, which is the disulfiram ethanol reaction. And there are a number of symptoms that are quite characteristic. They include flushing, weakness, nausea, heart racing, the heart feeling like it's pounding in the chest, sometimes people will say, and hypotension, so low blood pressure. This medication, there is no antidote for it. The treatment is supportive if someone were to drink and to develop these symptoms. But it's also true that the severity of the disulfiram ethanol reaction is directly proportional to the amount of alcohol that is consumed. And so sometimes if someone is taking this medication and takes a drink of alcohol, they will start to feel some symptoms, and that will stop them from continuing to drink. Some people do go on to develop a full-blown disulfiram ethanol reaction, but sometimes these things will be curtailed because the symptoms will start to be experienced by the individual, and they will self-curtail the use of alcohol. Now, the use of disulfiram is not to make people sick. It's not given to people so that if they drink, they get sick. The idea is to help to motivate them not to drink, because they know if they do, they risk becoming ill. But the idea is not to, for example, give people the medication and then give them alcohol to make them sick. That's not the way we use disulfiram, nor should it be used that way. It is a deterrent medication. There are some side effects to it. The things I've heard complained about most commonly is that kind of a metallic or garlicky taste in the mouth. Some people will complain of a sulfurish-like odor, but that's not usual. Rarely we will see toxicity in the liver or neuropathy or even psychosis. But again, those adverse events are fairly rare with this medication. There are some contraindications. This is not a medication for everyone. People who have heart disease, people who have esophageal varices and so are at risk for bleeding were they to drink while taking disulfiram and vomit. They risk rupturing their esophageal varices, so those are not individuals you would want to give this medication to. It's not to be used in pregnancy. Those who are impulsive and there's a concern that they may impulsively drink and perhaps drink a large amount in a short period of time are not good candidates for this medication. Those with psychotic disorders are thought to be more vulnerable to adverse events with disulfiram. And anyone with severe respiratory or renal disease, those with liver transaminases that are elevated, we generally think of 3 times above the upper limit of normal as being a relative contraindication to using disulfiram. People who take this medicine, they need to be given a lot of information about disulfiram. They need to be told to avoid alcohol and alcohol-containing foods. They need to be told how this medicine works and why they would become ill were they to drink alcohol when they were taking this medicine. Disulfiram, like any medication, really needs to be given to somebody who has given informed consent and fully understands what it is that they're getting involved with when they take this medication. The clinical dose is generally 1 tablet, and it comes as a 250 milligram tablet, although that tablet is scorable, and a dose range of 125 to 500 milligrams per day is generally what we think of with this medicine. Adherence is a problem with disulfiram. In fact, in the early days, back in the late 80s, there were several studies done that did not show disulfiram to be particularly effective, but one of the problems was that there was not good adherence to the medication. One of the advantages of a drug like disulfiram is that it can be started in a substance abuse treatment program or even in a clinician's office practice, and it can be monitored in that way. So it's really important that an individual participated in the studies did not take the disulfiram as directed. So let me move on to talk about naltrexone. Naltrexone is available in 2 formulations to treat alcoholism. The first one that became available or FDA approved for the treatment of alcohol dependence was a 50 milligram per day tablet, and then we now have extended release injectable naltrexone. This can be given as 1 injection per month at a dose of 380 milligrams. Again, with all of these medications, I mean, ambivalence it really is a hallmark of substance use disorders. I think that it's quite common for those with these disorders to be ambivalent about their sobriety. And one of the real advantages of a drug like naltrexone, particularly in an extended release formulation, is that you don't have to worry about the individual taking the medication every day. Let me just show you a little bit of data on this medication. This is from Stephanie O'Malley. This was one of the studies that the FDA looked at in thinking about the approval of this medicine for the treatment of alcohol dependence. And what she showed was a very significant difference in relapse rate in people with non-physiologic alcohol dependence. Those who were randomized to naltrexone, and this was the naltrexone tablet, so they were getting 50 milligrams a day. Those individuals who received naltrexone tablets had a longer period of time before they relapsed. And relapse was defined in this study as 4 or more drinks at a sitting. And you can see that those who were randomized to placebo had substantially greater rates of relapse. There was also a second study, which I'm not going to show the data on, but it was done by investigators at the University of Pennsylvania, Volpicelli and his colleagues, who showed similar results. And this led to the approval of naltrexone for the treatment of alcohol dependence. Now, why would a drug like naltrexone, that is an inhibitor of mu-opioid receptors, why would that work for alcohol dependence? Well, I don't think we have a firm reason. I don't think that we can say without a doubt that it's either of these explanations that I'm going to offer, but I think that a lot of us believe that endogenous opioids are released when people use alcohol, when they abuse alcohol. If you've blocked the opiate receptor, then these endogenous opioids, which are thought to be involved in the pleasurable effects of alcohol, can't have that effect. And so alcohol is a less reinforcing experience, the use of alcohol. And in addition, these endogenous opioids may also be involved in alcohol craving. And so if that opiate receptor is blocked, it's possible that an individual will experience less craving for alcohol over time. There are some safety issues to be aware of with the use of naltrexone. This medication has been cited for causing hepatocellular injury in some patients, but these individuals were actually taking very high doses of naltrexone, 5 to 10 times more than what the approved dose is, and so really important that the FDA-approved dose range be adhered to, and we're providing this medication to patients. Those who have acute hepatitis or liver failure are not medication. And it's also, I've given you the Veterans Affairs and Department of Defense guidelines on the use of naltrexone, and they recommend that liver functions be checked at baseline, and then once a month for 3 months, and then every 3 months after. In addition, if you have patients that are taking other medications that may also it's important to know that there can be additive hepatic effects. And so you want to think about what other medications the individual you're treating might need or be taking before this medication is prescribed. Other contraindications to naltrexone, I mean, really there aren't that many, but if you have someone who is taking opioid analgesics for a painful condition, for example, you wouldn't want to give that person naltrexone because it could precipitate opiate withdrawal. If you have somebody who's opioid dependent or in opioid withdrawal, again, not a medication you want to give such a person because it could worsen withdrawal symptoms or, again, precipitate withdrawal. If you believe that you have a patient who is likely to need opioid analgesics for some co-occurring condition, then naltrexone may be lower on your list of which medications to treat them with for their alcohol use disorder. And naltrexone is a Category C drug for pregnancy, which means that there have been some toxicities observed in animal studies, but there have not been human studies conducted. It's not absolutely forbidden in pregnant women, but the risk-benefit needs to be justified. The main adverse events that you see when you start to prescribe this medicine to someone, the most common side effects are nausea, some stomach upset, possibly some abdominal pain, and headache or dizziness. But these are generally mild and resolve fairly readily. If you start a person on naltrexone tablets, you can start at a dose lower than 50 milligrams. That's quite easy to do, and work them up to the standard therapeutic dose, and they do resolve these symptoms fairly readily. One of the things I do want to mention is I've heard some discussion about what effect naltrexone has on alcohol effects. Does it alter the effects of alcohol? And there are a few papers out on this, but I've got one that I've summarized here from McCall and colleagues. This was done with naltrexone tablets. This was a human laboratory study with 23 people where they looked at the effects of naltrexone, either placebo 50 or 100 milligrams a day, been given for at least 3 to 7 days prior to a challenge with alcohol. And the doses of alcohol they gave were either 0.5 or 1 gram per kilogram. And I can tell you from doing alcohol administration studies that 1 gram per kilogram will definitely produce intoxication. 0.5 grams per kilogram will produce milder alcohol effects, but definitely effects that can be detected by individuals that are experienced alcohol drinkers. What they reported was that naltrexone significantly increased subjective ratings of sedative and unpleasant or sick effects, and decreased ratings of liking, best effects, and desire to drink. And they also reported that alcohol ingestion significantly increased self-reports of intoxication, including high, drunk, and feel effects of alcohol or drugs. So this is not an anti-abuse-like drug. If this were an anti-abuse and alcohol study, these participants probably would have become much more ill. But it seemed pretty clear that people do not like the effects of alcohol, or at least most of those in the study reported ratings that would indicate that alcohol was not as pleasant an experience for them, but they definitely did feel effects of alcohol. So that's important to know, because this is quite different from what I'm going to talk about with naltrexone with opiates, where naltrexone actually does seem to block the effects of opiates. And I want to just mention acamprosate. Acamprosate is an amino acid derivative of taurine. It stabilizes excitatory neurotransmission, glutamatergic transmission that becomes altered during alcohol withdrawal. It is marketed as an anti-craving medication and possibly as a medication that can reduce some of the protracted withdrawal symptoms that some individuals who are coming off of alcohol will complain about. It is effective in reducing relapse to alcohol use. That was shown in studies that led to FDA approval of the drug, but it was not shown to be effective in Project Combine, which looked at acamprosate alone and in combination with naltrexone. Acamprosate did not appear to be an effective drug for the treatment of alcoholism. Now, I'll just say that while I think a pretty major study showed it not to be terribly useful, that is not to say that it is never useful. And this is a medication that can be quite important for those who have serious liver impairment. And so if you have a patient who has, let's say, severe hepatitis C, and they have severe alcoholism, and perhaps they can't take naltrexone, perhaps they can't take disulfiram because of the impairment in liver function, well, acamprosate is a medication that is cleared renally, and so it is an option, and I think an important option, at least in the folks that I work with. I see a fair number of people that have pretty severe liver impairment, and I have used this drug with some success, not in everyone, but with some success. And so I do mention this because I think it's an alternative that should be considered for appropriate patients. It does have some side effects. Diarrhea is reported at a fairly high rate, up to 16% in clinical trials reported this. Some nausea, some itching, although I've not had anyone complain about that. But like I say, I have not a huge population of people taking it. These numbers are from larger clinical trials where they were able to do good follow-up and determine what the most common side effects were. If you have someone with severe renal disease, you don't want to give them this medication. If they have a reduced creatinine clearance, you can cut the dose in half, but if they have a creatinine clearance that's less than 30 mils per minute, this is not a medication that you want to give to the person that you're treating. It does not have any abuse liability. It's not a hypnotic. It's not a muscle relaxant. It has no anxiolytic properties. It is difficult to adhere to because it needs to be taken 3 times a day, and they're 2 pills, and they are large pills that someone needs to take 3 times a day, and the recommended length of treatment is a year. So adherence can be an issue with this medication as well. Well, how do we think about selecting medications for alcohol use disorders? Generally, obviously I'm going to tell you the way I think about it, which is disulfiram for someone who is really committed to not drinking, somebody who's made that decision, and generally people who are at risk for heavy consequences of relapse. So where I've seen disulfiram used quite a bit, for example, is in impaired health professionals who have a license on the line and really cannot relapse. It would endanger their livelihood. Naltrexone, I think about for those who want to cut back, who want to get help for craving, and who want to determine over time whether they want to reduce or stop their drinking. There's a lot of flexibility with naltrexone, and as I mentioned, this is a medication that will help people with their craving and will also provide some effects if they do drink that will not be as pleasant as what they might have been expecting, although it will not. I have not heard, and from what I've seen with naltrexone, people do not get frankly ill with it. It's not an anti-abuse type drug. Acamprosate is for people who cannot use naltrexone, or naltrexone didn't work, or maybe they're going to need opioid analgesia, and disulfiram isn't an option for them. So that's a general way of thinking about approaches to medications for alcohol use disorders. Now, what about opiate addiction? Well, we're seeing increases in opiate dependence, and I'm just going to take a couple of minutes to say a few words about that because I think it's really quite an important issue today in addiction medicine. We see increasing use of opioids to treat chronic non-cancer pain. We know that more and more investigators are looking at this issue of addiction and misuse in those receiving these medications for the treatment of chronic non-malignant pain. And the recent literature estimates that anywhere from 4 to 26% of those receiving this medicine for the treatment of a painful condition will have an opiate use disorder or will develop an opiate use disorder as a result of using these medications. And of those without an opiate use disorder, up to 10% of them will misuse the medication. What does misuse the medication mean? It means that they will use the medication for something that the doctor didn't prescribe it for. So for stress, to relax, to go to sleep. Those are not reasons to use opiates. We consider those things to be misuse of opiates. This is data from the National Survey on Drug Use and Health from 2010, and what that survey told us was that 7 million Americans in the past month prior to answering the survey had misused prescription medications. This was led by opiates at 4.4 million people reporting misuse of opioid medications, And after that, CNS depressants such as sedative hypnotics, and then stimulant medications. Prescription pain medication misuse is now second only to marijuana in terms of abused illicit drugs in this country. And treatment admissions for opiate dependence have increased by fourfold in a 4-year period, with basically 100% increase in emergency department visits between 2004 and 2009. And this is also from the National Survey on Drug Use and Health in 2010. And what we see here is that 55% of people, when asked where did you get the medications that you misused, they say they got them free from their friends and relatives. And then another 15% said they bought them or they took them from a friend or relative that had medication. And another 17% got them from one doctor. When people were asked, well, when you got them free from friends and relatives, where did your friends and relatives get those medicines? 80% said they got them from their primary doctor. The reason I mention this is that this epidemic doesn't look like so many other epidemics with illicit drugs. So these, for the most part, are not drugs that are being bought from drug dealers, bought on the street. They are coming from prescribers, and people are sharing these medications, which I think really underscores the need for us to educate those who are receiving these medications of the risks and benefits of their use and the need to not share these medications. That can and does lead to adverse events, deaths, and addiction. I also show this slide because while it's important to check the prescription drug monitoring program, you'll notice that the number of people that describe getting these drugs from more than one doctor, even in 2010, it's still quite low. It's a little less than 2%. And so you may not, when you look somebody up in your state's prescription drug monitoring program, you may not see somebody that's getting controlled substances from one or more prescribers. It may be that the problem lies in the medications that are being gotten from one doctor, from the primary doctor. Now, here are the SAMHSA publications available for treatment of opioid dependence. And again, these are really quite well done. They're always done by experts in the field who have really given a lot of thought to their practice with these medications and the best and safest and most evidence-based means by which to use these medications. And so we have a SAMHSA advisory. This is called an Introduction to Extended Release Injectable Naltrexone for the Treatment of People with Opioid Dependence. I really like this, again, because it's short, it's very readable, and there's lots of really important information in it. There's also Tip 40, which is the treatment improvement protocol for the use of buprenorphine in office-based practice. And there's also Tip 43, which is medication-assisted treatment for opioid addiction in opioid treatment programs, which will tell you quite a bit about working in narcotic treatment programs and the use of methadone in treatment of opiate addiction, which is not going to be a huge focus of this talk. So let's talk for a few minutes about the treatment of opioid dependence. I generally think about this in terms of basically three types of options for those that develop problems with opioid medications or with heroin. The initial treatment could include medical withdrawal and include residential or intensive outpatient treatment, as well as individual and group drug counseling. I mention this not because I think medical withdrawal is necessarily the best treatment for opioid dependence, because I don't think that. But I do know from treating a lot of patients that for many, and it seems to be quite common in those who get into difficulties with prescription opioid medications, that they will sometimes say, I just want to get off. I don't want to be on this medicine anymore. I don't want to take this medicine anymore. You have to get me off. And so medical withdrawal can be a valuable treatment and a successful treatment for some individuals. The second option is to use medications to prevent relapse, and those would be, from office-based practices, those would be naltrexone, which it's important to note can only be used following medical withdrawal. So we cannot give this medication to people who are still physically dependent on opioids, because naltrexone has a strong affinity for the mu receptor. It can displace opiates that are there, and an individual can develop precipitated withdrawal if they receive naltrexone prior to being fully withdrawn from opioid agonists. And then the second medication is buprenorphine, and I'll talk more about that in just a moment. And then we have option 3, which is that of methadone maintenance, which for some individuals, particularly those who may need more structure, those who may need more medical intervention, those who may need ongoing opioid analgesia, they may benefit from a methadone program over a choice such as buprenorphine or naltrexone. But it's also true that you should know the options in your community. Not every community will have every option available, and it's important to know what is available in your own vicinity. So just to talk for a minute or two about naltrexone as a treatment for opioid dependence. Naltrexone is what we call an opioid antagonist therapy. It will block the effects of a dose of opiate, and that's been shown by Sharon Walsh and her colleagues. And so it prevents impulsive use of the drug. If a person is taking naltrexone and they use a dose of an opiate agonist, it basically will have little to no effect on them, and they do not get the expected response, and so that can help them in working on their recovery. There are high relapse rates following medical withdrawal or detoxification. I think naltrexone should be offered to individuals, particularly individuals who've had relapsing opioid dependence, who, for whatever reason, want medical withdrawal, who do not want to be maintained on a medication. They should be offered naltrexone treatment. We know that the relapse rates in the year following detoxification or medical withdrawal treatment exceed 80% if there is no follow-up medication management. And so, and frankly, we don't know what the relapse rates would be if we did routinely give a medication like naltrexone to those individuals who have relapsing disease. I hope it's a question that will be answered in the coming years, but we do know that people will relapse if they don't get further treatment. The dose of naltrexone, again, it can be used as a tablet, which was the first formulation that was FDA approved, and that was approved quite a number of years ago, is 50 milligrams a day, but you can give this medication as 100 milligrams every 2 days, and 100, even 150 every third day, so that if you have someone in an intensive outpatient program, for example, where maybe they're coming to treatment 3 days a week, they may benefit from witnessed administration of medication. The injectable naltrexone is a once-a-month injection. It's exactly the same dose as for the treatment of alcohol dependence. And again, the advantage of the injectable is that the adherence issue becomes, for to a large degree, a non-issue. And so many will benefit from that kind of an intervention. The other thing that I'll add here is that for people that have co-occurring alcohol use disorders and opiate use disorders, which is not uncommon, naltrexone is the only medication I'm going to talk about for treatment of opioid dependence that is also approved for the treatment of alcohol dependence. So that is something that's worth considering in your patients that have co-occurring disorders. So who gets naltrexone for opioid addiction? Well, generally, again, we think about highly motivated individuals, people who will have great consequences for relapse to opiate misuse, those who do not want agonist therapies or who do not want to take controlled substances for any reason, and some employer requirements will at times make naltrexone a better choice for some individuals. I'll talk for a few minutes about buprenorphine. Buprenorphine is in the agonist therapies, and I just want to, I always like to take the opportunity to emphasize that an agonist therapy is a long-acting medication that is in the same class as the abused drug, generally availing itself to once-a-day dosing to prevent withdrawal and to some extent induce tolerance, although I don't think any of the opioids induce complete tolerance to the use of another dose of a mu agonist. But what agonist therapy is not, it's not substitution of one addiction for another. Addiction is really about the behaviors related to obtaining, using, being intoxicated, and having withdrawal symptoms. When you can give an individual a once-a-day medication, they can get on with their lives. It's not the same thing as addiction, where they are constantly chasing the effects of the opiate that they're seeking. So buprenorphine is a mu-opioid partial agonist. It is on Schedule 3. And it has little effect on respiration or cardiovascular responses at higher doses. It's thought to be safer in an overdose situation, which is one of the reasons that it was approved as an office-based treatment for opioid dependence. However, having said that, it's important to recognize that no drug is completely safe, and certainly when used with other medications can become quite unsafe. Buprenorphine, like methadone, has been shown to be associated with significant adverse events and even deaths in those that misuse other illicit substances, and in particular benzodiazepine type drugs. So it's important to know that while this drug is safer than perhaps some other opioids, it can also be quite dangerous when used in combination with other medications that have similar central nervous system effects. The drug itself has a strong affinity for mu-opioid receptors, and it's slow to dissociate. So again, this is a drug that can be dosed once a day, and even there have been research reports that show that it can be given as little as every other day. So this is a long-acting drug. It does require induction. So the individual that's going to start buprenorphine needs to be in mild to moderate withdrawal before starting this medicine. Why? Because buprenorphine has a very strong affinity for the mu-opiate receptor, and it will displace full mu agonists on the receptors. And so if you give this medication in someone who has recently used a full mu agonist, then what will happen is that once that partial agonist, i.e. the buprenorphine, replaces that full agonist on the mu-opiate receptor, the individual will experience that as a drop in opiate function, and they will experience withdrawal symptoms. So the person needs to be in mild to moderate withdrawal, in which case buprenorphine will then relieve those withdrawal symptoms rather than making them worse. The maintenance form that is to be used in the United States is buprenorphine naloxone. That's a combination tablet. And the naloxone is there not as part of the treatment. Naloxone, when given sublingually, which is the way buprenorphine tablets are given, or buprenorphine strips, which are available now. When given sublingually, naloxone is not well absorbed, and so it has basically no effect. It is in the drug to decrease the likelihood of diversion to injected use. If you are a person that is an opiate abuser and you have recently used opiates and are physically dependent on opiates and you were to solubilize this drug and inject it, then there's a large amount of naloxone, which, as you know, is active when injected, when given parenterally, and that will make somebody have a precipitated withdrawal. So that's the reason naloxone is combined with buprenorphine. The only situation in which the mono formulation is used currently is in pregnant women, and again, that's because naloxone is not approved for the general use in pregnancy. The average dose of buprenorphine is going to be somewhere in the 8 to 16 milligram daily range, with probably most people falling in the 12 to 16 range. The FDA upper limit is 24 milligrams per day. Buprenorphine can be used for withdrawal treatment as well as for maintenance, and maintenance treatment is more effective than withdrawal treatment for all of the reasons I mentioned just a few minutes ago, and we now have specific studies that have been published that show that buprenorphine is no more effective than any other opiate withdrawal procedure or medication. It does have a milder withdrawal syndrome with it. However, that doesn't translate into longer periods of sobriety after withdrawal is accomplished. It's expected that primary care physicians, psychiatrists, and addiction specialists will be the providers of this treatment. Again, there is concern of abuse by injection, and therefore the buprenorphine naloxone is the most common formulation used to treat opioid dependence. And there are some drug interactions that have been observed with commonly used medications, for example, atazanavir, ritonavir, commonly used protease inhibitor combination used in the treatment of HIV disease can increase buprenorphine concentrations pretty dramatically, actually, and also increase concentrations of norbuprenorphine, which is thought to have some opioid activity as well. Whereas the tuberculosis medication, rifampin, really decreases buprenorphine exposure quite substantially, and opiate withdrawal has been observed in those taking standard clinical doses of this tuberculosis medication. But having said that, otherwise buprenorphine appears to have fewer drug interactions than, for example, than methadone, which probably relates to the fact that buprenorphine is primarily metabolized through cytochrome P450-3A4, whereas methadone has several cytochrome P450 enzymes that are responsible for its metabolism. One cannot simply prescribe this medication. This medication can only be prescribed currently by physicians, and those physicians must meet federal standards that are in statute in order to prescribe. And if they meet those one of those requirements, and generally most physicians will meet the requirement by taking a training on how to appropriately use the medication and how to treat opioid dependence, they will get what we call a DEA waiver, which is a second DEA registration number that is to be used when prescribing this medication. I'm going to speak just very briefly about methadone maintenance. Methadone maintenance can only be used for the treatment of opioid dependence from specialized narcotic treatment programs. I mentioned earlier that there are There are some people who will benefit from this intervention, those needing more structure, those who benefit from more frequent interactions with staff, those who have pain and addiction, often those with co-occurring mental illness, benefit from the kinds of interventions that the staff and methadone maintenance programs can readily make with them. It's also a long-acting mu agonist. It lasts for somewhere between 24 and 36 hours in most individuals. The dose is a philosophical issue still for many programs. We know that 30 to 40 milligrams will block opiate withdrawal, but it won't block craving. Illicit opiate use has been shown to decrease when dosages in the range of 80 to 120 milligrams per day are used. This is currently the average therapeutic dose range in the United States. There are some programs that tend to dose on the lower end, and others that will dose in this 80 to 120 milligram or higher, even higher range. But again, this is generally something that is often specific to the programs offering this treatment. So why is all of this important? Well, because we know from a number of different types of surveys, but particularly from the National Survey on Drug Use and Health, that about 10% of Americans will meet diagnostic criteria for a substance use disorder. These are chronic relapsing diseases that are likely to recur once they've been diagnosed. And we have effective pharmacotherapies that can be implemented in primary care, they can be implemented in mental health treatment programs, and they can be implemented in specialty alcohol and other drug treatment programs. Untreated substance abuse, it will negatively impact other diseases present, such as alcoholic cardiomyopathy, such as chronic obstructive pulmonary disease, or HIV, or hepatitis C, and other infectious diseases. And undiagnosed substance use disorders can masquerade as illnesses that the patient does not have. For example, hypertension, or seizure disorders, or mental disorders. And so it's important to recognize and treat for the best clinical outcomes in those that suffer from these disorders. Substance use disorders also can contribute to non-adherence to prescribed regimens, and they can contribute to toxicities in those that must take other medications or who are using other substances in terms of drug interactions. So important to diagnose and treat these conditions and to use medications when appropriate. As Dr. Parad was saying, these medications are not used at nearly the frequency we would expect given the prevalence of these disorders in the United States. And I will end by talking just for a moment about the clinical support systems available to clinicians using these medications. These are sponsored by the Center for Substance Abuse Treatment, and they include the Physician's Clinical Support System for buprenorphine, which is a training and mentoring program for those wishing to establish an office-based practice for treatment of opioid dependence. And we have the Prescriber's Clinical Support System for opioid therapies. This is a consortium of a number of large national constituency groups that offer training through a variety of mechanisms, including webinars. We have a website with modules about specific topics in safe opioid prescribing, and modules that train on the treatment of opiate dependence, as well as other related topics that are important to safe opioid prescribing. We have a listserv where experts can answer questions that people have as they practice in this area. We also are developing a phone app for people to use that will give them access to reference materials to assist them in safe opiate prescribing. And over the next 2 years, we will also be developing a similar phone app for the treatment of opioid dependence. So we do encourage you to use these programs. These are available at no charge to everyone, and we hope that you'll use them and find them useful. And I also have included references if you'd like to look at any of these studies that form the basis of this talk in a little more detail. And I will stop there. And thank you for your attention.
Hi, thanks, Dr. McCann-Skatz. Dr. Perard again from CSAT SAMHSA. I do acknowledge that we are a little bit over time, so what I would suggest for question, if those of you can stay and have question, please, you can certainly basically share those questions with us now. However, if you have to go on to another activity, what you can do is to email your question to Leslie. Her email was mentioned on the webinar invitation, and so I will open the floor for discussion. And again, if you have to go, you can always send those questions to us.
And at this time, feel free to use the chat function, which is in the lower right section of your screen, and I can read those questions aloud. I will also open up the line in case there are any folks on the phone who would just like to go ahead and call out their questions. And again, my name is Leslie McGilligan, so if you have a question, you can always feel free to email me. Do we have any questions at this time? Okay, I don't think we have any at this time. Oh, actually, I'm sorry. I do have a question about the copies. Will they be made available? And I have recorded this session, and I will share the recorded copy with SAMHSA, as well as posting it to our SBIRT grantees on the VLC.
Can I ask you a question?
Yes, please go ahead.
Yeah, my question is the injectable form of naltrexone more effective in terms of reducing the the pleasure response of either drinking and or opioids than compared with the oral naltrexone?
Yeah, so I don't think there have been any head-to-head studies of that. If there are, I'm not aware of them. But here's what I would say is that the drugs are fairly equivalent in terms of their effect, but the effect on opiates, naltrexone is a good blocker of opiate effects, and it appears in individuals who are naltrexone responders in terms of alcohol dependence, it appears to alter in a fashion that makes them crave alcohol less and to use less alcohol if they do drink. And so that's an important aspect for alcoholism. And there are the advantages, of course, that the injectable takes away the issue of having to take a medication every day. So that's very important for some people. But in terms of a study, I don't know of a direct study that has looked at those issues. Perhaps there is, but I'm not aware of it.
Thank you.
I don't have any other questions at this time, Dr. McCann-Scott.
Okay.
Okay, well, thank you again, Dr. McCann-Scott and all on behalf of SAMHSA. And so as a reminder, if any question were to come up, you can always email Leslie, and her email address is on the webinar announcement. So thanks to all.
Thank you. Bye-bye.
Thank you.
Bye.